Well, I was invited to give a presentation about bispecific immunotherapy in ALL, and so the topic is to discuss what has been developed so far. Bispecifics are a new class of biologicals which should bridge the T cells to engage with the respective tumor targets. It's highly specific because you select a tumor target that's only expressed in a certain lineage, like in ALL it would be CD19. And the current lead technology is being presented basically by the data generated through blinatumomab, which is a very simple construct, as it is only taking out the VLVH regions of a respective CD3 antibody to attract the T cells, and a corresponding VLVH region targeting CD19 abundantly expressed antigen on the cell surface of ALL and healthy B cells. So blinatumomab has been explored in large phase 2 and phase 3 trials, leading to registration of blinatumomab by the EMA, FDA, and also by other health agencies across the world. So the first indication where a bispecific has been successfully used is in MRD positive ALL. So those are patients who have still trace of the leukemia by minimal residual disease assessment. Two buckets of patients. One is the patients which are in continuous first remission versus patients in second or third continuous remission. So they have really relapsed and had a salvage chemotherapy and still are MRD positive. And blinatumomab was then used as a single agent to convert MRD positivity into MRD negativity. And if the patients were responding, then they would go on to receiving a transplant, an allotransplant, because that is the traditional way of treating patients who are MRD positive after frontline therapy. So the key result is that 80% of these patients actually achieved this primary endpoint, and that when you look at an overall survival at about 5 years, there's a significant difference in favor of blinatumomab treated patients who reached an MRD negativity versus patients who were MRD positive after blinatumomab. And the other key result is what is the role of transplantation in this cohort of patients, and it appears that patients who get a consultation, an allotransplantation after blin-induced CR, do better than the ones who don't get a transplant. So the second bucket is indication is refractory ALL, where traditionally the response rates to chemotherapy are somewhere between 20 to 30%, with just an overall survival of roughly 3 to 4 months. And here we have a phase 3 trial where the patients were randomized between both blina versus SOC chemotherapy, intensified chemotherapy. And the key messages of that trial that was published in New England Journal is that 45% of the patients treated with blina reached a CR, whereas the patients treated with SOC chemotherapy was lower than 30%, so that's significant, which then led to a almost doubling of the overall survival in the patients who were treated with blinatumomab to 7.7 months versus 4.0 months. And then if you ask the question, which patients do benefit most from this approach, is the patients in salvage 1, so with the first relapse. Here we can show that 11.1 months is the overall survival of those patients, so that is highly significant, of course, when compared to chemotherapy. We've done also now a small subgroup analysis based on the phase 2 trial, where patients were taken to transplantation after blin-induced CR, and the treatment-related mortality 100 days was 12%, and for patients under the age of 35, so with the sequence CR induced by blinatumomab onto transplant, the median overall survival has not yet been reached. So this seems to be quite beneficial when compared to historical controls in that context. But the problem that we are facing with this monotherapy is twofold. We have patients relapsing which have lost CD19 expression, and we have patients who don't respond. So to the first, CD19 negativity occurs in about 20% of the patients, and it's actually a little bit lower than with the CAR T-cell therapy, which also engages with CD19 targets, where there has been about 50 to 60% of the patients who relapse have lost expression of CD19. There has been some elaborate work looking at the mechanisms. At least it appears in CAR T-cells that it is just exon splicing, that is the major resistance mechanism. With blinatumomab-induced, it appears as a different mechanism, and Monica Bruggeman will report on that at EHA. But what we also sometimes do see is myeloid outgrowth or lineage switch. So the cells just become completely devoid of any B-cell markers and express myeloid markers, and still yet can be easily traced to be driven from the original leukemic clone. So that is one problem that we're facing. And how do we get around this problem is, well, there are other antigens that are expressed by BLL that can be targeted, CD20, CD22, and CD123, and my lab has looked into this a little bit more in detail because there is a bispecific out there in clinical trials for AML and has shown CR rates or objective response rates at ASH about 22% as monotherapy. So in the lab we looked at that and how to use this as an antigen to target also BLL, and it appears that with fresh bone marrow samples, unfractionated, that we can purge those bone marrows from the ALL. And most interestingly is we combine that with blinatumomab. We can actually lower the amount of blina and flotusimab, which is the drug targeting 123, quite significantly, leading to a greatly reduced production of cytokines, because that is the hallmark of side effects, is cytokine driven. And so it appears that we can kill two birds with one stone: antigen escape, more pressure by targeting two antigens, and on the other hand lowering the rate of cytokines that are produced by the respective T cells in this in vitro assay. So that is one problem that we do see. And the other one is that the T-cell compartment differs between patient to patient. So some patients have a fairly normal T-cell compartment with normal ratios between CD4, CD8 cells and TREG cells. And there are other patients who have a completely altered proportion of these different subsets of T cells. We looked into this and we found that patients who have a very high number of T regulatory T cells, and there's a threshold above 8%, that none of these patients respond to blinatumomab in that context. So with that said, you can rethink about strategies how to reduce the amount of regulatory T cells up front, and cyclophosphamide is an agent that we would highly recommend because it has been shown in the past by other groups that can actually specifically deplete this T cell population. Potentially we can overcome here a deficit with that. So in summary, we have with the bispecifics one agent that is now approved for two indications, in ALL, MRD positive ALL, as well as relapsed refractory ALL. But there's more to come as we learn more about what are the resistance mechanisms and how can we improve on the tweaking the immune system to be even doing a better job.